This is a recorded lecture for Chapter 17, the cardiovascular system, and we're going to discuss the heart in this first group. This is a chapter that really deals with a lot of different areas of the cardiovascular system, primarily the heart, to include the architecture of the heart, the anatomy, the physiology as far as how the heart pumps blood to the rest of the body, how the heart provides blood to itself, that's through the cardiac vessels, if you will, that feed the very demanding muscle of the heart, and also the electrical system of the heart that allows it to pump in a very simultaneous sort of way and to be very functional. It's a very involved physiologic chapter, and so the heart itself is more than just a simple pump, though it is hydrodynamically a simple pump. The architecture that makes it a simple pump is pretty involved, and so I challenge you that you'll have to spend some time going through this again and again, because it takes a while before it sticks. The average heart's about the size of your fist. It's located in the mediastinum, in the thoracic cavity, and between the second rib and the fifth intercostal space. It sits on the superior surface of the diaphragm, and it's 2/3 of it are the left of the mid-sternal line, the mid-sagittal line that runs through the sternum. It is anterior to the vertebral column, but posterior to the sternum, and is enclosed in a double-walled sac of pericardium. We look at the mid-sternal line, which also is also the same as the mid-sagittal line, goes right down there. You can see there's the second rib across. You see the heart sits just below the second rib. It sits, there's the diaphragm, so it sits right on the diaphragm. You can see it sits substernally, but a little more of it's on the left side than the right side. So about 2/3 is really located on that left side, about 1/3 is located on the right side. The PMI, which is the point of maximum intensity, or where you hear the heart the loudest, is really about the fifth intercostal space, if you will, and about just a peristernal area. When we open it up and we see the thoracic cavity, you can see there's the pleural cavities, and between them is that mediastinum. And so when you think about where that sits, you can get a good feel for how the heart sits inside of that mediastinum. The bottom of the heart is called the apex of the heart. The top of the heart, the apex of the heart is the bottom of the heart. We'll just leave it at that for right now. And you see that the apex of the heart sits right over the diaphragm proper. You see that the superior vena cava, as it enters into the heart, it comes that way, and you can't see the inferior vena cava because it's been cut away. What you're seeing through here is you don't see the aorta as it leaves the heart going to the body. You can see the pericardium, which has been cut away to expose the heart proper, so you get a good feel for what we're talking about. The pericardium is a superficial fibrous layer that protects, anchors, and prevents overfilling of the heart proper. Pericardium is a 2-layer serous membrane, and the parietal layer is the outside layer, and it lines the internal surface of that fibrous pericardium, or the mediastinum proper. The visceral pericardium, that's the pericardium that is intimately touching the heart proper, is also called the epicardium. And it sits on that external surface of the heart, and it's separated, the parietal layer and the visceral epicardium layer is separated by a fluid-filled pericardial cavity, which helps to decrease friction of the heart pumping. It's a really nice depiction of layering as we get to the heart chamber proper. You can see the fibrous pericardium, which is really the layer that makes up that the mediastinum. You see the parietal layer of the pericardium. You see the pericardial cavity, the space there. You can see the epicardium, or the visceral pericardium, and then you see the myocardium. Myo means muscle, cardium means heart muscle. And then you see the endocardial layer, that's the inside layer of each chamber of the heart, and then the heart chamber proper. So it gives you the idea as you go from outer to inner layer of the heart proper. The epicardium is a visceral layer of serous pericardium. So the epicardium is really that visceral layer. It's just another name for the visceral layer, actually. We talk about the parietal and the visceral layers. The myocardium, myo means heart, or means muscle, cardium means heart, is made up of spiral bundles of cardiac muscle cells, and we've seen those cells before. The fibrous skeleton of the heart is a crisscrossing interlacing of connective tissue, and that helps to anchor the cardiac muscle fibers and supports the great vessels and the valves. It also limits the action of potentials to specific paths. So it limits the action potentials to specific paths, limits the neurovascular, or the nervous, if you will, activation. The endocardium is a continuous endothelial lining of all the blood vessels as well as each chamber of the heart. The heart has 4 chambers. We'll talk more about that later. So the endo means inside, cardium means inside the cardium. And again, we've seen this before. You see the fibrous outer layer. You can see the parietal layer of the serous pericardium. You see that potential space is filled with a little bit of fluid. You get a nice feel for the epicardium, also called the visceral pericardium. You see the muscle tissue there. That's it's called the myocardium. And then you see the endocardium, which is that inner layer there that is continuous to the endothelium of blood vessels. It's an endothelial layer. And then you see the heart chamber. There's just an opening there. So you get a kind of feel for what we talked about. There's the bands of the cardiac muscles and how they lay. You can see that there's the right atrium, left atrium as you go there. And you see this almost figure-8 effect of cardiac muscle as it extends down into the ventricle area of the heart. As I said, there are 4 chambers of the heart. There are 2 upper chambers called atrium, or each one is an atria. They are separated internally by an interatrial septum. Septum means a separator. There's a coronary sulcus, which is the atrioventricular groove, which encircles the junction of the atria and the ventricles. And the auricles increase the atrial volume. So we'll talk a little bit about that in just a minute. We'll show you. The 2 lower chambers are the ventricles, and they're separated by the interventricular septum. They have an anterior and posterior interventricular sulci, which mark the position of the septum externally. And so when we look at this, you get a nice feel for what we're talking about. There's that nice right atrium that we talked about. There's the left atrium and the auricle of the left atrium. You get the feel for that. And you see the atrium pretty small seen on the side, and part of the left atrium kind of sits behind the great vessels, the pulmonary trunk as well as the ascending aorta. And then what you're seeing here is the anterior view. You get a nice feel for the right ventricle, if you will. And you can see that right there. And there's the left ventricle. And so they're very large. You see the ventricles are quite large as compared to the rest of the heart. They make up the bulk of the heart. The atria, the receiving chambers as they're called, the upper 2 upper chambers, the walls are ridged by what are called pectinate muscles. The vessels entering the right atrium, that being as you look at this, the right atrium proper here, are the superior and inferior vena cava as well as the coronary sinus. Now, when we go back and look at this slide again, you can see there's the superior vena cava coming in and the inferior vena cava coming in. They meet, if you will, and they come together and create that right atria. The vessels entering the left atrium, that being this other side over here, the vessels enter there, are really blood returning back from being oxygenated in the pulmonary system, and all vessels that come to the heart are veins. All vessels where the blood flows away from the heart are arteries. So the blood is coming back to the heart from the lungs, and that they come back via the pulmonary veins from the lungs proper. The ventricles are called the discharging chamber. Ventricles are the 2 lower chambers of the heart. The walls are ridged by trabeculae carneae. The papillary muscles project into the ventricular cavities. The vessels leaving the right ventricle are the pulmonary trunk. That is, the right ventricle pumps blood to the heart, or to the lungs proper. It takes deoxygenated blood, pumps it to the lungs to be oxygenated. And then the left ventricle actually has a exiting vessel also, and that's oxygenated blood that is being sent out the aorta out to the body. And so when we open the heart up, you get kind of a nice feel. There's the superior and inferior vena cava meeting at the right atrium, and that's deoxygenated blood coming from the body. That goes through, if you will, a valve called the tricuspid valve. The tricuspid valve allows blood to enter the right ventricle. From the right ventricle, blood is pumped out the left pulmonary arteries and the right pulmonary arteries to the lungs. The blood goes to the lungs, and returns back from the lungs oxygenated, you see it's red again, via the pulmonary veins, the left and right pulmonary veins, which enter into the left atria. From the left atria, blood is pumped through the mitral valve. It is then collected in the left ventricle and is pumped out the aorta, going through the aortic valve. Now I left out one part here, and that is that the right ventricle, when it pumps blood out to the pulmonary arteries, blood leaving the heart our arteries, then it does through the pulmonary valve. You'll hear that pulmonary valve. All right? So you kind of feel for what we're talking about here. The heart is really two side-by-side pumps, the right and left side. The right side is the pump for the pulmonary circuit, and the left side is the pump for the rest of the body, the systemic circuit. The right side are the vessels that carry blood to and from the lungs, and the left side of the vessels that carry blood to and from the body tissues. And here's kind of how it works. Blood comes from the body and enters the right side of the heart. It enters via the superior and inferior vena cava into that right atrium. From the right atrium, it goes to the right ventricle. From the right ventricle, it goes to the pulmonary valve, to the pulmonary arteries to the lungs. The lungs reoxygenate the blood. The blood returns via the pulmonary veins. Any blood that comes back to the heart comes back to the pulmonary veins. Pulmonary veins enter the left atrium. The left atrium then shoots the blood through the mitral valve into the right ventricle. The right ventricle contracts, shoots the blood out to the body as oxygenated blood. It's there that oxygen is left off, and carbon dioxide is brought back on, and the circuit is complete. The right side of the heart is oxygen-poor blood. The left side of the heart is oxygen-rich blood, based on how that happens within that circuit. The pathway of blood to the heart is as follows. The right atrium goes to the tricuspid valve and the right ventricle. The right ventricle pushes blood to the pulmonary semilunar valve. It's a bilunar, two-leaflet lunar valve, to the pulmonary trunk, into the pulmonary arteries, the left and right lungs. From the lungs, the blood comes back through the pulmonary veins and it enters the left atrium. The left atrium, through a bicuspid valve we call the mitral valve, shoots blood into the left ventricle. The left ventricle then contracts, shoots blood through the aortic semilunar valve of the aorta. The aorta then carries the blood to the systemic circulation. The pathway of the blood to the heart, there are equal volumes of blood are pumped to the pulmonary and the systemic circuits. The pulmonary circuit is a short, low-pressure circulation, where the systemic circuit blood encounters much resistance because it's a long pathway, because it's a great big circuit. So the anatomies of the ventricles really reflects these differences. That is, the left ventricle is very large, and the right ventricle is a little bit smaller. You see here that the left ventricle is a really large ventricle, and the right ventricle looks like it's been kind of slapped against the really large muscle of the left ventricle. So most of the heart is really left ventricle. A smaller part of the ventricle is really the right ventricle. The coronary circulation is how the heart supplies blood to itself. And the arterial supply varies considerably and contains many anastomoses or junctions among the various branches. There are also collateral routes that provide additional routes for blood delivery. So if one of the vessels gets blocked, there's a method for the very demanding tissue, very demanding muscle of the cardiac muscle, to get circulation from somewhere else. The arteries include the right and left coronary, and that's located in the atrioventricular groove, the marginal, the circumflex, the anterior interventricular arteries. The veins include the small cardiac, the anterior cardiac, and the great cardiac veins. We look at the two major coronary arteries. We're seeing the right coronary artery, and we see the anterior interventricular artery going around that little groove, if you will, of the interventricular groove. So there's the left coronary artery, if you will, as it comes down. There's the circumflex artery that comes off. There's the anterior interventricular artery. You also see off the right coronary artery that right marginal artery, if you will. So this is the anterior aspect of the artery system. Also anteriorly, here's the cardiac veins. You can see the anterior cardiac veins located here, the great cardiac vein located right here, and then the coronary sinus, which is kind of an enlarged vein right here, and that gives rise to the middle cardiac vein right there. You see the small cardiac veins also coming off the anterior cardiac veins. Now posteriorly, there's a whole different view here. What you're seeing here is you see that the middle cardiac vein located right here. You get a feel for the great cardiac vein that comes around here, and it becomes the posterior vein of the left ventricle. So that's the posterior aspect of the arteries proper. We talk about homeostatic imbalances in the heart. We have two things we really talk about, which is angina, sometimes called angina pectoris, and a frank myocardial infarction, which is really the heart attack. Angina is really thoracic pain caused by a fleeting deficiency or inadequacy of blood delivery, more likely the oxygen, to the myocardium. So if not enough blood is getting there, carrying that life-giving oxygen, then you have pain. And the cells are weakened, but they don't die. Angina pectoris is really not enough oxygen. Myocardial infarction is death of tissue. So if you have prolonged coronary blockage or blockage of the coronary arteries, the areas where the blood isn't getting to die and are repaired with what are called non-contractile scar tissue. So once that dies, it's never replaced with good muscle again. And at that point in time, it takes about 6 minutes for the heart muscle to really die. The heart valves help to ensure that the blood goes in one direction only, so it ensures a unidirectional or one-directional blood flow to the heart. You have the atrioventricular valves. Those are the valves that separate the atria from their respective ventricles, and they prevent backflow in the atria when the ventricles contract. They include the tricuspid valve, which is the right valve, the right atrioventricular valve. Tricuspid meaning three cuspids or three leaflets that go together. And then there's the left side, which is the mitral valve, which is a two-leaflet valve or a bivalve. The chorda tendini are really strands of papillary muscles that anchor the valves and keep them, allow them to snap shut and open correctly. We also have what are called the semilunar valves. The semilunar valves are the valves that allow the blood, they're the place where the blood goes through when the ventricles contract, and they prevent backflow in the ventricles. They include the aortic valve, which is a semilunar valve, which means that there's two half moons, if you will, that leaflets that close it, and the pulmonary semilunar valve. The aortic semilunar valve is located in the left ventricle. The pulmonary semilunar valve is located in the right ventricle. If we look at the heart, we see the pulmonary aortic area you see the cutaway right here. There's the mitral tricuspid valves. So we're looking at the heart right here. We see the pulmonary valve. We see the pulmonary valve. Let's get where we sit here. There's the myocardium, if you will. There's a tricuspid valve, three valves here, if you will. There's the mitral valve. That's there's a two valve, or if you will. And then you see that aortic and that pulmonary valve. Now what's really funny is it's called a semilunar valve. These are semilunar valves, but it shows here with three leaflets there's really only two. Kind of interesting. We look at the myocardium. We're really looking at the muscle of the heart. There's that tricuspid right atrioventricular valve, and there's the mitral valve, the left atrioventricular valve. There's the pulmonary valve, which is really there, and there's the pulmonary valve as we see it there. This is if you're looking at that on a piece of actual cadaver. This is the active action of blood flowing to the heart. This is done with what's called a MUGA scan. So they take a radioisotope. They inject it in the veins, and then they take a MRI, and that shows where things are happening. So you can see the chordae tendinae, that actually hold those valves in place attached to the tricuspid valve. And there's that papillary muscle we talk about. There's the opening of the inferior vena cava, if you will. There's the tricuspid valve. There's the myocardium of the right ventricle. There's the interventricular septum, and there's that myocardium of the left, if you will. And you see the little chordae tendinae right there that hold that mitral valve in place. Now, this is kind of a track of how we're going to do as far as how things work. Initially, blood returning from the heart fills the atria, putting pressure against the atrioventricular valves, and finally the atrioventricular valves are forced open based on that pressure. As the ventricles fill through the valves of the atrioventricular valves, that being the tricuspid and the mitral valves, the atrioventricular valve flaps hang limply into the ventricle. Once the atria contract, forcing the additional blood into the ventricles, And then what happens is the ventricles contract, and they actually increase the pressure of the ventricles, and it forces the atrioventricular valves to close. In the world of heart sounds, that's the lub. The first heart sound is really the atrioventricular valve closing. The papillary muscles contract and the chorda tendineae tighten, preventing the valve flaps from everting into the atria, so they close right up. As the ventricles contract, the interventricular pressure rises, the blood is pushed up against the semilunar valves, forcing them to open. So the aortic valve and the pulmonary valve open. As the ventricles relax and the interventricular pressure falls, blood flows back, tries to flow backwards, and forces the semilunar valves, that being the aortic and the pulmonary valves, to close, and that snaps them shut, creating the dub. So the lub-dub, the lub is the closing of the AV valves, and the dub is the closing of the semilunar valves. We look at the microscopic anatomy of cardiac muscle. We see the cardiac muscles are striated, they're short, they're fat, they're branched, and they're interconnected. The connective tissue matrix, the endomysium, connects, endomysium, you'll hear that term also, connects to the fibrous skeleton. The T-tubules, as we discussed, we talked about the muscular system before, are wide, but they're less numerous. The sarcoplasmic reticulum is simpler than in skeletal muscles. They have numerous large mitochondria. In fact, 25 to 35% of the cell volume is made up of the mitochondria, so many, many mitochondria. So there's the nucleus. See the intercalated discs there located in the cell, and you see the cardiac cells, and they flow together kind of like the roots of a tree. You see gap junctions, if you will, located there, and the desmosomes as it holds the various cells together. The intercalated discs are junction between the cells, and they anchor the cardiac cells, and the desmosomes prevent cells from separating during contraction. That's pretty important. Gap junctions allow ions to pass, and so they're electrically couple the adjacent cells, so that the heart muscle behaves as a functional syncytium, which means it contracts in a very systematic sort of way. And that means that it contracts the atria, then it contracts the ventricles, and it does that in a very systematic, very predictable sort of way. You see the cardiac muscle cell here. There's the intercalated discs. We're looking at them. There's the multiple mitochondria in the nucleus of that. You see the T-tubules. We see it here. There's the mitochondria again. There's the sarcoplasmic reticulum we talked about. Remember the Z disc. There's the I-band, A-band, and I-band. And again, there's the sarcolemma, or that surrounding layer over that muscle cell. Cardiac muscle contraction is really a very rhythmic and systematic and spontaneous sort of process. Depolarization of the heart is done in a very rhythmic sort of way, obviously. About 1% of cardiac muscles actually have automaticity. That is, they self-excite. They can actually cause contraction on their own. The gap junctions ensures the heart contracts as a unit. Now, it doesn't all contract at one time. The atria contract and the ventricles contract. And then there's an absolute refractory period of about 250 microseconds between contractions, so that the heart doesn't have one steady contraction. The way that cardiac contraction works is there's depolarization, which opens up the voltage-gated fast sodium channels, just like we talked about before, in the sarcolemma. The reversal of membrane potential, that is sodium, going from the extracellular to the intracellular cell proper, changes the membrane potential from a -90 microvolts to a +30 microvolts. The depolarization wave in the T-tubules causes the sarcoplasmic reticulum to release calcium. The depolarization wave also opens the slow calcium channels in the sarcolemma. Calcium surge prolongs the depolarization phase, creating what's called a plateau. And here we have it. We have depolarization, which is really due to the sodium influx through the fast voltage-gated sodium channels. A positive feedback cycle rapidly opens many sodium channels, allowing sodium to come from the extracellular area to the intracellular area, and reversing the membrane potential from a -90 to a +30. Channel inactivation ends this phase. The plateau phase is really due to the calcium influx through the slow calcium channels, and this keeps cells depolarized because the few potassium channels are open. Repolarization is due to calcium channels inactivating and potassium channels opening. This allows the potassium efflux, which brings the membrane potential back to its resting state, and thus to go through a process. So there's depolarization, repolarization. Calcium influx triggers the opening of calcium-sensitive channels in the sarcoplasmic reticulum, which really liberates bursts of calcium too. The EC's channels coupling occurs as calcium binds to troponin and allows the myosin and the actin filaments to slide, if you will, and contract. Duration of the action potential, the contractile phase, is a much greater in cardiac muscle than skeletal muscle, so it's a much greater process. And the repolarization results in the inactivation of calcium channels and the opening of the voltage-gated potassium channels. There's an intrinsic cardiac conduction system, which is the electrical vent of the heart. It's a network of non-contractile autorhythmic cells that initiate and distribute impulses to coordinate the depolarization and contraction of the heart. The autorhythmic cells have unstable resting potentials, that is, pacemaker potentials or pre-potentials, due to open, slow sodium channels. At threshold, calcium channels are open. Explosive calcium influx produces a rising phase of an action potential, and then repolarization results from inactivation of the calcium channels and opening of the voltage-gated potassium channels. And this takes you to that process. So these are cells that are self-automating, self-exciting. The pacemaker potential of the cells, the slow depolarization, is due to both opening of the sodium channels and the closing of the potassium channels. Notice that the membrane potential is never a flat line, so this is what happens. Depolarization, the action potential begins when the pacemaker potential reaches threshold. There it is right there, reaches the threshold. And then the depolarization is due to calcium influx through the calcium channels. And then finally, repolarization is a process where the calcium channel is inactivating and the potassium channel is opening. This allows potassium efflux, which brings the membrane potential back to its original state, and so the heart is triggered again, or recocked again. We look at the neurovascular, obviously the nervous system of the heart. We actually follow the heart through several sequences or several entities, anatomical entities. The first is the sinoatrial node, often referred to as the SA node. The SA node is called the pacemaker of the heart. It generates impulses about 75 times a minute, and that's referred to as the sinus rhythm, sinoatrial rhythm. It depolarizes faster than any other part of the myocardium, and so this is the SA node is part of the nervous system. The atrioventricular node is the node that separates, is where the electrical stimulation comes from the atria and then runs into the ventricles. So it's the atrioventricular node. It has a smaller diameter fibers, fewer gap junction, and it actually delays the impulses about 1/10 of a second before after they cause contraction of the atria. It causes about 1/10 of a second delay before the ventricles contract, allowing the atria to completely disengorge the blood into the ventricles. It depolarizes 50 times per minute in the absence of the SA node input, so it can discharge on its own. The atrioventricular bundle, sometimes called the bundle of His, is the only electrical connection between the atria and the ventricles. The right and left bundle branches. There's two pathways in the interventricular septum of the heart that carries impulses to the apex of the heart, and they're called the right and left bundle branches. And then finally, the PHGY fibers are the fibers that are located in the outer layer of the myocardium, and they complete the pathway in the apex and the ventricular walls. The AV bundle and the PHGY fibers depolarize about 30 times per minute in the absence of any AV input. And so when we look at that, here's how we follow that. We see that the pacemaker node, the SA node, which is located in the superior wall of the right atria. And we see that it discharges, it causes contraction of both atria. The electrical stimulation goes to the AV node, where there's about 1/10 of a second delay before it continues down to the atrioventricular bundle, which is the bundle that starts at the AV node and runs down till it splits in the septum, the ventricular septum, into the right and left bundle branch. The bundle branches then extend down until they get to the apex of the heart, and they continue up through the ventricular wall, the outer ventricular wall, as the Purkinje fibers. You also see Purkinje plexus of all of that. And you'll see that. So electrical stimulation is atria, delay, ventricles contract. Atria contract, delay, ventricles contract. So you get kind of a feel for how that all works. We can have homeostatic imbalances in that conduction system, which the defects in the intrinsic conduction system can result in all sorts of things. We get arrhythmias, which is irregular heart rhythms. We get uncoordinated atrial and ventricular contractions, so they contract in very different ways. We can get fibrillation, where there's kind of this shaking, if you will, this rapid irregular contractions, which doesn't pump anything. And arrhythmias can be very ineffectual for pumping blood also. So all of these cause ineffectual pumping. That way we don't actually get oxygen to, or blood, if you will, to the heart and the rest of the body. So that's the problem. Some of the homeostatic imbalances include a defective SA node, where that may result in what's called an ectopic focus, where we get another part of the heart becoming a pacemaker. It's abnormal. If the AV node takes over, that means the junctional rhythm occurs, or the rhythm starts not from the atria, but from that AV node, and the rates drop from 70 to 75 beats a minute to about 40 to 60 beats per minute. If you have a defective AV node, it could result in a partial or a total heart block, so that the delay, which is usually 1/10 of a second, becomes much longer. Or there could be a complete heart block where no impulses get through into the ventricles. The heartbeat can be modified by the autonomic nervous system. The cardiac centers are located in the medulla oblongata. So the cardio-acceleratory centers innervates the SA and the AV nodes, the heart muscle, and the coronary arteries through the sympathetic neurons. The cardio-inhibitory centers inhibits the SA and AV nodes through the parasympathetic fibers in the vagus nerve. Remember, the vagus nerve is one of the coronary, cervical, the cervical nerves that we talked about before. This takes you through that process. So the vagus nerve is the parasympathetic, decreases the heart rate, and it goes this way. You can see that that's the parasympathetic. In the sympathetic phase, you see the part starts the medulla oblongata. It goes down through the thoracic spine, leaving the thoracic spinal cord, the sympathetic trunk, and then enters the heart, as we talked about, in the SA and AV nodes. So you get a feel for what we're talking about. We talk about innervation coming from the electrical system. We talk about the heart. We look at the rhythm, if you will, of the contraction phase. We do that looking at what's called an electrocardiogram. Now, electrocardiogram would be ECG, electrocardiogram. Electro meaning electricity, cardiac meaning heart, gram meaning report. But ECG and EEG are very similar, and so many years ago, several decades ago, it was changed to instead of ECG, the term EKG came into place because K was hard to mix up with the E, if you will. So it's a composite of all the action potentials that generated by the nodal and contractile cells at a given time. The heart makes actually three major waves. It makes a P wave, which was caused by the initial depolarization of the SA node, a QRS complex, which is really the depolarization of the ventricles, and then a T wave, which is the ventricular repolarization. The part that's missing here is repolarization of the atria, and I'll explain how you don't see that in a regular EKG. So here's the initial P wave, which is the atrial depolarization. You see the QRS, which is a ventricular depolarization, and then repolarization of ventricles at the T wave. What happens is that atrial depolarization actually occurs within the ventricle depolarization and gets kind of washed out, so it gets lost within this. The action potential of ventricular depolarization is so great that the atrial repolarization gets kind of lost. You can see that the PQ interval is the interval from the beginning of the P to the beginning of the Q. You can see the QT interval is the beginning of the Q wave to the end of the T wave, and the ST segment is really the delay between the return of S to the threshold and the beginning of the T wave. As we go through here, you get a really good feel for atrial depolarization. That you see that the P wave is created, initiated by the SA node, causing the P wave. Step 2, with the atria depolarization complete, you see that happening. The impulse is delayed at the AV node by that 1/10 of a second. There's the delay. That's called the PQ or the PR interval. We then have a ventricular depolarization, which occurs when the electrical stimulation, the action potential, gets through the septum, the ventricular septum into the apex, causing that QRS complex, and the atrial repolarization occurs, but it's hidden inside of that. In the next step, we have ventricular depolarization, which means the ventricles have totally depolarized, and that creates that little space right here. When the ventricles start to repolarize, that is, they repolarize back to the norm, it begins the apex, causing that little T wave to occur, and finally ventricular repolarization is complete, and we have a flat line again. And that we've really taken you through that, and I'm not going to go through that again, but this takes you through step by step that process we just discussed as we're talking about the repolarization process. These are looking at EKGs proper. There's a normal sinus rhythm. There's a P wave, see a QRS, and a T wave. P wave, QRS, and a T wave. And if you look at the QRSs, you'll see they're very regular. If you were to take a piece of paper and mark it, you can take those marks and move them anywhere along this rhythm, and you'd find that it works just fine. If the SA node is non-functional, the P waves then go away because you don't have an SA node discharging, and the heart is paced now by the AV node, and so it's a little slower. It's about 40 to 60 beats per minute, and you see the QRS and the T wave, but no P wave. When there's an increased delay through the AV node, which is called a heart block, and they come in 3 flavors: first, second, third degree heart block. What you're seeing, sometimes you'll see a P wave, but the block causes no QRS to occur sometimes. Sometimes you'll see a P wave and there'll be a QRS, but sometimes you'll see a P wave and there's no QRS. So in this case, this is kind of a rhythmic second degree heart block because you have a P, nothing. You have a P, QRS, T. P, nothing. P, QRS, T. P, nothing. And so it actually does not discharge the ventricles every other time. When there's fibrillation, there's no regularity whatsoever, and this causes a chaotic EKG, which is really just the muscles quivering, and that's what happens in an acute heart attack or electrical shock. We know the heart sounds are really 2 sounds, the lub-dub, and that's associated with the closing of the heart valves. The first sound occurs as the AV valves close, that would be the tricuspid and the mitral valve, and signifies the beginning of systole, or the contraction, if you will, of the heart. That's the active action of the heart. The second heart sound occurs when the SL valves, the semilunar valves, close in the beginning of ventricular dystole. So when they close, that being the pulmonary and the aortic valves close, that begins, if you will, ventricular diastole, which is the resting of the heart. So once the dub occurs, the heart's in diastole or resting. Systole is when the heart's actively contracting. It's through systole that the blood pressure rises and gives you the high blood pressure number. It's through diastole that the heart is resting and the blood pressure falls, giving you the diastolic blood pressure. Heart murmurs are when there's abnormal heart sounds, most often indicating valve problems, so the valves don't properly open. The aortic valve sounds are heard in the second intercostal space at the right sternal margin, best over the aortic valve. The tricuspid valve is best heard at the right sternal margin of the fifth intercostal space. The pulmonary valve sounds are heard best in the second intercostal space of the left sternal margin. And finally, the mitral valve are really heard best over the fifth intercostal space, mostly in the mid-clavicular line or the middle of the clavicle as you go down. So called the mid-clavicular line. The cardiac cycle, there is really all the events associated with blood flow through the heart during one complete heartbeat. The contraction phase is called systole, and that's when the blood pressure increases. Diastole is when the heart is refilling, and that's when the blood pressure generally decreases. The phases of the cardiac cycle, first is ventricular filling, which takes place in the mid to late diastole. The AV valves are open. 80% of the blood passively flows to the ventricles. Atrial systole occurs, delivering the remaining 20% of blood from the atria to the ventricles. The end diastolic volume, EDV, is the volume of blood in each ventricle at the end of ventricular diastole. During ventricular systole, the atria relax and the ventricles begin to contract. The rising ventricular pressures in the left and right ventricle result in the closing of the AV valves, the mitral and the tricuspid valves. The isovolemic volumetric contraction, phase, all valves are closed. In the ejection phase, the ventricular pressure exceeds the pressure in the large arteries, forcing the semilunar valves to open. That is, the pulmonary valves from the right ventricle to the lungs, the left aortic valve from the left ventricle into the aorta. The insystolic volume is the volume of blood remaining in each ventricle. And finally, the isovolumetric relaxation occurs in the early diastole. The ventricles are relaxed. The backflow of blood in the aortic and pulmonary trunk forces the SL valves to close, the semilunar valves, that's being the pulmonary and the aortic valves, to close, and causes what's called a dicrotic notch, or a brief rise in the aortic pressure from that backflow. This takes you through that. It's located in your book, and you kind of follow that. It's a good combination of showing you what happens throughout the heart as all those things are happening. Cardiac output is the volume of blood pumped by each ventricle in 1 minute. So cardiac output is the heart rate, HR, times the stroke volume, SV. The heart rate is number of beats per minute, and the stroke volume is really the volume of blood pumped out by the ventricle with each beat. So, cardiac output in mils per minute is really the heart rate, 75 beats per minute, times, as I said, the stroke volume, which is the volume of blood pumped out by the ventricle in each beat, stroke volume, and that equals 5 1/4 liters per minute. So each ventricle pumps approximately 5 liters per minute. The maximum cardiac output is 4 to 5 times the resting cardiac output in a non-athletic person. The maximal cardiac output may reach 35 liters per minute in trained athletes, so they can really make that move. And the cardiac reserve is the difference between the resting and the maximal cardiac output. The regulation of stroke volume, with stroke volume equals EDV minus ESV. There are 3 main factors affecting stroke volume: the preload, the contractility, and the afterload. Preload. Preload is a degree of stretch of the cardiac muscle cells before they contract. This is called Starling's law, now called Frank Starling's law of the heart. That basically says the cardiac muscle exhibits a length-tension relationship. At rest, the cardiac muscle cells are shorter than the optimal length. A slow heartbeat in exercise increases the venous return. The increased venous return distends or stretches the ventricles and increases the contraction force, like a rubber band kind of thing. Then the muscles are actually like a rubber band, are super contracted, and then when they're stretched out, they almost get a reflex from the heart proper just from that stretching, the reaction or the reflex from stretching. Contractility, the contractile strength at a given muscle length, independent of the muscle stretch at EDV. Positive ionotropic agents increase contractility. If you increase cardiac influx due to sympathetic stimulation, hormones, thyroxine, glucagon, and epinephrine all make that happen better. Negative ionotropic agents decrease contractility, and that includes acidosis, increased extracellular potassium, and calcium channel blockers, which are used sometimes to decrease blood pressure and to manage the heart. So those are just ways to look at that. This takes you through the steps that happen. We talk about the contraction process. We've seen this chart many times. This is the plasma membrane. You see norepinephrine coming to that first receptor protein, which causes an activation of the GDP. The GDP then activates a secondary protein, adenylate cyclase. Adenylate cyclase can cause an inactive protein, kinase A, or an active protein, kinase A, and all sorts of things can happen downstream, and you get kind of a feel for how that happens down the road. We talk about regulation of stroke volume, we have to talk about afterload. And afterload is the pressure that must be overcome for the ventricles to eject blood. That means the ventricle pressure has to be greater than the resistance created from the blood that's located in the arteries leaving the heart. For instance, if you have high blood pressure, then when the left ventricle contracts and shoots blood out the aorta, it makes it much harder for the aorta, the left ventricle, to compress enough to get all the blood out and get past there to equal the pressure of the arteries, if you will. Same with if you have pulmonary hypertension. The right side of the heart cannot contract enough to shoot the blood efficiently through the pulmonary valve in the pulmonary arteries and going to the lungs. So hypertension increases the afterload, resulting in increased ESV and reduced stroke volume. The regulation of the heart, the positive chronotropic factors increase the heart rate, negative chronotropic factors decrease the heart rate. The autonomic nervous system regulation, the sympathetic nervous system, is activated by emotional physical stressors. Norepinephrine causes the pacemaker to fire more rapidly and at the same time increases the contractility of the muscle proper. The parasympathetic nervous system opposes the sympathetic effect. The acetylcholine hyperpolarizes the pacemaker cells by opening potassium channels. The heart at rest exhibits a vagal tone, which is parasympathetic. The atrial Bainbridge reflex is a sympathetic reflex initiated by increased venous return. So the stretch of the atrial walls stimulates the SA node. It also stimulates atrial stretch receptors, activating the sympathetic reflexes throughout the cardiovascular system. So exercise by the skeletal muscles and respiratory pumps, you see that before in Chapter 19. Heart rate allows more time for ventricular filling. There's increased venous return. There's an EDV preload that, if you will, the blood-borne epinephrine and thyroxine and excess calcium come in, increasing contractility. ESV decreases, stroke volume increases cardiac output. When we have cardiac exercise fright or anxiety, the sympathetic activity, the parasympathetic activity, both have effect on the heart rate, which can manage cardiac output, as you can see. Chemical regulation of the heart can be hormonal. Epinephrine from the adrenal medulla enhances heart rate and contractility. It enhances or facilitates or exacerbates increases. Thyroxine increases heart rate and enhances the effect of norepinephrine and epinephrine. Intra and extracellular ion concentrations, in other words, calcium and potassium, may be maintained for normal heart functions, because they must be normal. If you don't have enough calcium or potassium, heart functions will change abruptly. Other factors that influence the heart rate: age. Age makes it harder for the heart to do work. Gender. Males usually have a more muscular heart than females. Exercise. Exercise increases the optimal ability of the heart. Body temperature. The hotter you are, the less functioning your heart is, because your body has to work to manage that increased hyperthermia. Tachycardia, by definition, is any heartbeat greater than 100 beats per minute. If it persists, then it may lead to that fibrillation we talked about, where the heart isn't really contracting but just shaking. Bradycardia is when the heart rate is slower than 60 beats per minute. That can result from grossly inadequate blood circulation, and it may be a desirable result of endurance training. Many of your super athletes have a heart rate of about 52 beats per minute. And so they can, especially the Ironman triathletes and all that, when they go out and exercise, if they go out and run a half a mile, their heartbeat goes right up to 60 from 50 or 40. One of the problems that we talk about, the homeostatic imbalance, is congestive heart failure, referred to as CHF. It's a progressive condition where the cardiac output is so low that the blood circulation is inadequate to meet the tissue needs. So the heart isn't able to keep up the blood supply necessary. It can be caused by coronary atherosclerosis, or scarring of the coronary arteries, persistent high blood pressure, multiple heart attacks, or dilated cardiomyopathy, where the heart is so dilated, like a rubber band gets super stretched and doesn't have the contractility it had before. All right. So we talked about homeostatic imbalance of tachycardia and bradycardia. We've talked about the heart. We've talked about the cardiac system, meaning the heart, part 1. This has been the recorded lecture, Chapter 17 of the cardiovascular system. Thank you.